and so on. And he's going to be talking about detection of asymptomatic malaria. Right?
Thank you very much. First of all, I thanks Professor Olivo and GenRe team for supporting me to sharing my project for you today. And first of all, I would like to introduce myself. I'm graduate from tropical medicine at Mahidol University with under supervision with Professor Malika Imbong and also Professor Aryan Dondrop. So that we have 2 years before, I have been worked with Moru for 2 years. And after that, I went to be the lecturer at Chulalongkorn University. And right now, until today, we close collaborate with Moru and tropical faculty of tropical medicine at university and Mahidol University too. So today, we would like to share high sensitivity detection of asymptomatic malaria using droplet digital PCR. So this is the result from the WHO that the malaria still have a higher number of the cases right now until in this year that we aim to eliminate malaria in this region, GenRe-Mekong sub-region. So that's why we are here today. So, but there are still the case, but it's decreased, so it's very good. But right now there are very high case of the Plasmodium vivax that everyone concerned. And this is for the malaria situation in Thailand that from the Thailand team have already said, let you know that there are lower of the case until year 2021. And after that, there will have an increasing case in malaria in Thailand after the pandemic of the COVID-19, maybe have a cross-border area and maybe population drive cross-border. And we aim to eliminate malaria in all species in this region in year 2030. So the key challenge of that's very difficult to eliminate malaria in this region. The first one is a drug-resistant parasites that GenRe have generate a lot of data about the resistance to tracking, especially in falciparum. And right now, the falciparum trend is way have a decrease, right? And have a mobile and migrant population, especially maybe have some mobile and migrant population from Myanmar to Thailand, and maybe have a lot of can close together, and maybe mobile and migrant population, forest and forest fire transmission. And the important one is asymptomatic malaria reservoir. We have to identify who have malaria inside, and maybe we providing them a treatment and maybe clearance the parasite in the blood circulation. So the challenge of the asymptomatic malaria is quite very important. It's a major obstacle malaria elimination. It's very low density parasite escape diagnostic, especially RDT or under microscopic examination, and maintain reservoir, and maybe it can cause a transmission. And we require the sensitive screening for that. And this is the like a overall limitation of the diagnostic assay. For example, microscopic examination maybe have maybe 50 to 100 parasites per it can detect, but lower than this one it can difficult to detection. And maybe also for the RDT is very is limited sensitivity for low parasitemia. And also the standard PCR, maybe conventional PCR, and can detect maybe roughly 100 parasites per ml of blood. And it all of this maybe cannot detect submicroscopic examination. And for the droplet digital PCR, this technology can maybe like a real-time PCR, but it can be separate the reaction into maybe 20,000 droplets. And this is a use the endpoint PCR in each droplet. And after that, not for the real time, the result from the real time is quite the CT is like a threshold. Maybe have a lower CT is mean that very high parasite in the samples, right? And for the droplet digital PCR, it means that if you see how many positive droplets among the total of the droplets, so we can providing absolute quantification in the unit of copy per microliters. And this is the overall of the droplet digital PCR technology assay, including prepare the ddPCR master mix, and after that generate into the small droplets, and after that perform the PCR and then read the result one by one in each droplet to see which one is have a positive signal of the fluorescent or not, and which one is not. And for the ddPCR advantage over the qPCR, for example, did not require any standard curve and high precision and with less variation, and maybe can detect low density infection and direct inter-laboratory comparable. And this is the ddPCR malaria detection. I would like to say that this technology is emerged for firstly in year 2011, and after that maybe in year 2017 we have developed the droplet digital PCR for the genus level, for detection at the genus level, and after that perform to identify in each species with the Plasmodium falciparum, vivax, malaria, and also overlay. From the pipeline that we think that we have to screen first with the genus level, because the primer and probe decides that the conserved region of the genus level. So it's providing us to screening which one is positive or negative. And after that, the sample that positive with the genus level, we go to the species level. So it can be very quick to screening, and after that can use for identify in each species. At that time, it didn't have a pandemic of the Plasmodium noci yet. So we have developed only falciparum, vivax, overlay, and malaria. And after that, in year 2020, there have been a research have been developed Plasmodium vivax and Plasmodium noci together in the duplex reaction to identify Plasmodium vivax and Plasmodium noci. And then in year 2022, they have the identified parasite malaria in the saliva sample using droplet digital PCR in this one, but only for Plasmodium falciparum and Plasmodium vivax, not for other species. And in year 2023, there are research have been developed the multiplex ddPCR for identify falciparum, vivax, malaria, and Plasmodium overlay into 2 subspecies. And this year, recently in year 2025, this is from our team. We have using the digital PCR to screening in asymptomatic malaria patient in the border area, and also the soldier that come from back to Thailand, and we screen for the asymptomatic malaria. And this is the publication in year 2017 that we have developed the droplet digital PCR for screening at the genus level, and after that identify in each species, including PF, PV, PM, PO. And they provided very high sensitivity to detect of the parasites. And this is that we have optimized the droplet digital PCR. Maybe if you apply this technology, maybe you have to validate in each laboratory, and maybe you have a cross-check together, and after maybe provide the samples, and after that we will get the same result or not, okay? And this is from our previously publication. We have performed the duplex ddPCR assay because we would like to reduce the cost per sample. So we combine together with Plasmodium falciparum and Plasmodium vivax together, and Plasmodium malaria and Plasmodium overlay together is like a panel for checking that, okay? And this is for the identification mixed infection that we would like to demonstrate that maybe for the real-time PCR. We combine it together in for example, number 7 sample. We mix very high parasite of Plasmodium falciparum with very low parasite of Plasmodium malaria together, and maybe misdiagnose with the real time, but it can diagnose with the ddPCR results. And the same, maybe we mix together with very high parasite of the Plasmodium vivax and very low parasite of Plasmodium malaria together, maybe misidentified. And the droplet digital PCR and maybe previously conventional PCR is have developed and diagnosed based on 18S rRNA genes. This gene is like it have a multi-copy genomic region. So it have a one parasite, it have carry a lot of this gene copy. So it's providing high sensitivity and providing very low limit of detection. And also in the species-specific marker for Plasmodium falciparum, vivax, malaria overlay, and noci also developed on these genes. And this one is have the develop of the Plasmodium noci and vivax together. And recently, we there have a research that have developed droplet digital PCR with other genes we call PVR47 for Plasmodium vivax and PFR364 for Plasmodium falciparum. This is very high copy number. It's like a multi-genetic marker that may be providing very high sensitivity combined with droplet digital PCR, and they apply this to using identify malaria in the saliva samples. And in year 2023, they have developed multiplex together. And this is where they use the different color channel from the rocks, cis, hex, fam, combine. It can like one reaction, it can identify into each species. And this is our recently have been using the droplet digital PCR for screening asymptomatic malaria in high-risk Thai population. And this one of the study population, we collaborate with the Army Force Research Institute in Medical Science, Bangkok, Thailand. We are collecting the sample specimen from the individual malaria endemic region in Tak province, total roughly 400 samples, using the fingerprint from the dry bath, and after that we collecting the dry bath spot from them in Tak province. And we also have a Thai worker, the soldier have returning from the high risk area from the Sudan, and then back to Thailand. We screening 270 samples from the Thai worker that back to Thailand from Sudan. And we use both specimen type for first venous blood from the soldier that come back to Thailand from Sudan, and also using the dry blood spot. It's like a field and stable storage and transportation. We collecting only the blood spot from the person who live in endemic area in Tak province. And this is the workflow that we have performed. And we found that microscopic examination of this is quite all of the person who lived in the Tak province is all of negative. And both we also have DNA extraction and detect it using the droplet digital PCR assay at the genus level. And we found one person get positive with Plasmodium vivax. And also the EDTA blood collecting from the worker who returning to Thailand from South Sudan. And we performed the microscopic examination. We found that positive only 7 cases in 270 samples. And we performed the droplet digital PCR. We found the positive in 20 samples. So this is the result from the genus level. We confirm with the genus level first, and after that we have to identify into the species level, because we would like to reduce the cost for screening. And this is from the detection rate of using the digital PCR. So it can be used for the surveillance, screening, and elimination program, and maybe used for the drug efficacy study and treatment monitoring, because it's like for the digital PCR is providing us absolute quantification. Maybe you can collecting blood from the day 0, day 1, day 2, and day 3, and after that you can measure the parasite level in absolute quantities. It maybe can see there are any the result of the resistance or not. And this is maybe implementation from my experience that we use the dye-bud spot only for screening. After that, we extract the DNA from the dye-bud spot at our laboratory and confirm with the droplet digital PCR. And this is the malaria-free project community residence in the border area of Thailand. I and my team also collaborate with the Rak Thai Foundation, World Vision Foundation, Tak Province, and Allied Thailand Organization to go to the community-based Tha Song Yang in Tak, and also in Kanchanaburi, and also inศรีสะเกษ okay, we screening around roughly 588 samples from the individual who stay in the border area using the dye-blood spot compared with the rapid diagnostic test. And we found the case that have the positive in the case of using the dye-blood spot. And after that, we extract DNA and perform the droplet digital PCR. So, but it's, the droplet digital PCR is remain high cost per sample and maybe require specialized equipment and training. But it will be not used for routine clinical. But maybe if you would like to apply this technology, maybe you can apply with the dye-blood spot, and after that you can screening first at the genus level to reduce the cost. After positive with the genus level, you can go to the other assay to identify in each species, may be useful. And for the future direction, for the drug-resistant marker, we also have validate droplet digital PCR for accurate measurement of gene amplification of Plasmodium falciparum. This one we have been developed the droplet digital PCR assay for measurement of the DNA copy number of Plasmodium MDR1, Plasmodium 2. And also, it's like a quick tool for identify the KIL13 mutation also for the droplet digital PCR. And it can providing us the minor population of the mutant among the very high wild type strain. So this is for the example. You can see that there are number of the positive for the mutant, and this one is positive for the wild type. Maybe you can track easier if they have the minor population in the blood, in the samples or not, using the droplet digital PCR. This is screening for the KIL13 mutation. So I would like to say that droplet digital PCR maybe can optional for use for the ultra-sensitive detection and detect submicroscopic examination for supporting malaria elimination. And this for all my presentation. Thank you.
Thank you very much. Any questions here on the ddPCR techniques? Oh, sorry, Dr. Sil.
In terms of the practical for the National Malaria Control Program, even right now, the standard PCR is hard to use that sensitivity result to treat patients because they try to say that it may not a disease because they detect more sensitive already. But now come out with another ddPCR that more sensitive than standard one. And so in terms of operational or implementation for the program, I don't know whether this can be used or I think that if you use this for others purpose like drug resistant monitoring, the mark or resistant may be more helpful rather than be applied for operational for treatment, something like that.
What is your
yes, yes, thank you very much. This is for my experience directly, because when I went to the Tak province and I get the patient that I went to the Tak province, and after that I screening using only the dye-blood spot, and I carry that into our laboratory in Bangkok and identify who she is have infected with the malaria parasite and identify with Plasmodium vivax. And after that, I call back to the hospital and maybe to see that. And after that, the hospital bring she back to the hospital to confirm using the microscopic examination. But at that day, the results show no didn't have any parasite in the blood circulation. And after that, maybe after 2 days, she have the symptom and back to the hospital again. I think it's maybe quite a very early detection before a symptom occurs. And this is a confirmed case again, maybe after she developed the symptom. And this is a tool maybe you can only detect and maybe awareness and maybe have to control in the community base that maybe have some asymptomatic in the village or not. And after that, you have beware in the community base. And if in the future they have the policy to believe maybe PCR, conventional PCR or real-time PCR is like for the other conventional technique to confirm together, is maybe help us to concern and maybe you can have a treatment or not.
Okay. Good. Any other questions? Yes.
Okay, thank you. Very nice presentation. Good job. And each time I hear high sensitivity test, I'm very happy. And the problem is, what is the cost and how long? Normally, if we do PCR already, it takes time to have the results, and which are the PCR. How long does it take? And is it possible to implement in the district or province? Can you tell more? Thank you.
So how do the costs compare?
Compare with for the right now in Thailand, maybe rapid diagnostic test maybe $2 for the RDT. From the real-time PCR and conventional PCR, roughly maybe $4 and for the droplet digital PCR maybe 8. I think it's quite more expensive, but it can multiplex together and maybe screening using the genus level before you identify into species to reduce the cost. For the turnaround time, we after perform the DNA extraction, maybe the DNA extraction maybe 1 hour for DNA extraction from each sample, maybe batch 96 well plates. And perform the 96 samples, maybe using 4 hours to complete the genus level. And
Yes.
maybe take for other 4 levels, 4 hours for species level.
Okay. Cindy, you want to ask a question?
Yeah, just a technical question. On the dry blood spot, do you just take a punch? How much do you take of the blood spot?
The blood spot that we concern the quality control also. We would like to maybe we measure 20 microliters of blood. It's equivalent to the diameter to the one centimeters of the diameter using the dry blood spot.
Okay, so you take the whole full spot.
Yes, whole full spot.
Okay. Sorry.
How many droplets do you test in the DBS? How many spots you take?
Only one spot. One spot.
Yes.
But when we collect 3 spots. 3 spots because if one spot have a positive, we cut other 1 spot to confirm it together independently to confirm that have the positive because it's have a asymptomatic so.
Dokwan.
Thank you. So I have a question, maybe a bit far from your PCR technique. So should we conduct the same treatment for all the case positive by your PCR technique? Because some no parasitemia, some asymptomatic case, they maybe not become the case, and then maybe not become the source of infection. So should we conduct the treatment, the same treatment for all the samples confirmed by your PCR?
I think this depends on the policy. from the soldier that come from the Sudan, and after that, I collecting the blood sample, and we reported that have the case of positive with the Plasmodium falciparum. After that, they choose the same drug with the symptomatic patient. So use the same.
A lot of PCR positive samples, I think they cannot become the clinical case. They cannot become the source of infection. And if we put a lot of resource, a lot of treatment for those PCR confirmed positive samples, I am not sure how about the cost effectiveness, how about the contribution to your national treatment policy or guideline. Yeah, thank you.
That's pretty controversial, yes. No, but thank you. I think it's a very valid observation. I also sit on the fence there, and that's why I kind of like, to collect symptomatic cases, because then we know that they can have a clinical effect. Yeah, thank you. Rita.
Yeah, we had discussions around this in Laos about what to do with the PCR positives, and in conclusion, we decided not to put them in the surveillance system because they may not always be a case, and also when we're bringing in more sensitive diagnostics, where suddenly case numbers will be very patchy if we're just using PCR in different places and can increase. But then definitely to treat them. That was the conclusion. Because we're going for elimination.
So they're not cases, but you treat them?
Yeah.
Okay.
Yeah.
Oh, this WHO speaking.
But no. But this was if they're asymptomatic. If they're asymptomatic, if we do like a screening in a like a mass drug administration type setting where we're screening the village and people are asymptomatic and they're PCR positive, they are not counted as a case, but they're treated as a case.
Thank you.
Yeah, I was just going to say, as a follow-up to your question, I think that part of what he's saying, and maybe what you're saying, is for many years we had discussion. I think from Siv's discussion too in Cambodia many years ago, we had this discussion of what is the role of low parasitemia, right? And can there be a lot of transmission from that in the future? Or do we really have to find those individuals and target them to get to elimination? And there was a lot of discussion about that, but then people said, well, what about places like China? Or what about places like Sri Lanka or other places eliminated earlier? That they seem to have got there without that. And I guess the question is maybe, more theoretical or more of a research question, and there's no real answer. Maybe some country is different than another country. But it seems to me that the question of, you're right, there's this underlying question of like, if you have really low parasitemia that's just kind of hanging around in some places, does that really ever end up in having more clinical cases coming up later? And as time continues to move on, maybe 10 years on now from Sri Lanka's certification or others, we don't see that yet.
Yeah. Well, if I can just say, you can always say, oh, such and such did it without this. Italy did it without all this, but we had DDT and we ruined it for everyone else. So, but the circumstances change, and it's hard to say really, because we're not in the same place as before, So, yeah. Sorry, that was probably quite obvious, really. But
just a point, I think they've done the mosquito feeding studies where they show that asymptomatic parasitemias do transmit to the mosquitoes. Yes. So maybe it's a numbers game. Most mosquitoes might not pick up enough blood. But if you have a big explosion of mosquito population and you have the one asymptomatic person or a few, or 50% in some places, then you might actually continue transmission. So I think it is important to treat the asymptomatic cases. But in China, did they do MDA to get to elimination? There wasn't MDA, okay.
Well, thank you. That was an excellent discussion. If there are no further questions on this, then thank you very much.